Welcome to Let's Talk About Health, an informational podcast that gives you insights on health and fitness from experts themselves that you can apply directly to your own personal health and fitness stories. Come join me today to hear all about what they have to say on health and fitness. Well, I know you've had a very busy day. How has your day been going?
It was great. I'm a sports medicine surgeon, so I got to, fix a lot of knees and shoulders today in the operating room. We think we did one cartilage transplantation where we took a plug of bone and cartilage and we took it from a donor fresh, got shipped in, matched for size, and we put it in a defect in a football player's condyle,
Wow.
actually in his patella, in his kneecap, to give him a new surface because he's been kind of catching and popping as he bends his knee. So that restored his knee, and he'll be ready for football this summer. So it's kind of that's very rewarding. That when you get to help someone like that, that's a pretty big operation, but it only takes like 40 minutes. So it's kind of neat.
I love the fact you make it sound so casual, like
Yeah.
it's a big operation, but 40 minutes, yeah.
I'll see him in clinic tomorrow morning in the football training room at 6 a.m. So he won't even be awake yet. He'll be in a stupor.
But that's so interesting. It's so fun, which is one of the reasons, I was so passionate about medicine to begin with.
Yeah.
I remember one of my teachers, he showed me a heart transplant when we were very young. We were 11, 12 years old. And he wanted us to he wanted us to be introduced to blood and just biology and surgery, what it is all about. And while my friends were puking their guts out, I was like, oh my God, what is happening? Did he really remove a heart and replace a new one? And that person is life? It blew my mind, and I fell in love with science, biology, medicine.
It is amazing. I mean, no matter at what level, whether it's, small animals, large animals, in the veterinary world, helping them. Done a fair amount of that during my training, but, helping when I was in the Army forever, just helping other soldiers and their families, stay on the, what we call the friendly fields of strife. The athletic fields is, it's rewarding because people get to stay in the game. Whatever their game is, we try to get them back doing what they like to do. And it's empowering. It's small. It's not saving their lives, but it's saving quality of life.
That's what's more important, I feel. Yeah. You were telling me about your veterinary life. Can you tell me a bit more?
So in orthopedics, we love doing research and clinical research, and a lot of it still in the U.S. certainly is I'm not a veterinarian at all. I never trained as one, but we do a lot of large animal research to learn different techniques and to try different things out in the animal world and do animal research before we can translate it to our friends, neighbors, and colleagues. We don't like to experiment on humans' knees, shoulders, so we have to know it's going to work before we get it approved or accredited by the FDA or by any approving authority. So we have to know it'll work. So in my learning years, education years, I spent a whole year doing large animal research, and I got to do revision ACLs in goats, lots of goats.
Wow.
And I became a goat herder. Not really. They were all tagged electronically on their nap of their neck so we could they all look the same because, you're like, I don't know, A from B. They all had numbers. They were digitally tagged so we could see how they did.
Yeah.
And you learn one thing when you do large animal research. It's feeding the animals that costs the most of any study. It was $250,000 in goat feed because we did it for 3 years.
Wow.
Incredible. Yeah. So we got a nice grant. We didn't pay. I mean, we paid for it, but somebody else. But we learned a lot. So that was translatable to the human operating room where we could say, hey, we've learned a lot of interesting things in that study to help make ACL reconstruction, the main ligament we fix in a lot of humans' knees, better. So we made it a little better mousetrap.
Yeah. I love that. Because I'm trying to relate. Why goat?
Goats, well, they're simple, they're resilient. Their knee is somewhat similar when you talk about like an ACL to a human knee. It's not cost prohibitive, and you got to titrate that in because if you can't finish the study and do it, you don't have the numbers to get the the power statistically to say anything useful. So if you're going to go through a 3-year study and spend a lot of money, you got to know you've got a system in place that will get you from A to Z. And the vets that I work with, the orthopedic vets, said the goat's a great model for knee stuff.
Oh,
Certain other things too, it can be, but sometimes we like different size animals. You know, we like to go with the smallest animal possible. I did some external fixture pins. They always get infected, or they can. So we looked at an infected external fixture model in rabbits for that same year,
wow.
because rabbits, we could, you know, work on their injury in their muscle, and we did X fixes in goats too. But we started in rabbits. We were doing like in the Army. We did a lot of Army research because I was the U.S. Army Institute of Surgical Research. We looked at critical muscle defects. So if you get, you know, mangled extremity is the analogy in war, in your bed rest, was there a way to medically help you get back your resiliency and your muscle tone? So we're actually working with something called anabolic steroids, which are actually not legal. You couldn't go get anabolic steroids, but we're, from a scientific standpoint, we tried to show that, you know, giving rabbits a controlled dose of certain kinds of anabolic steroids could defeat the muscle atrophy and breakdown, and actually help heal the muscle defect that we experimentally created, so that we could thwart bed rest. Because, you know, if you get, you know,
Yeah.
really bad, you're at bed rest for a week or two, and you lose your muscle mass. And if you're a soldier in the military, that's horrible. You can't go back to being what you're supposed to be. So it was a study, but again, we looked at the smallest animal that we could do the experiment in and still get useful data to translate to the human experience. So, you know, you say, oh, you're working on animals. That's good and bad. I mean, we take it very seriously, and it gets approved by all sorts of levels of authorities, internally and externally. So it's highly, you know, regulated, but it makes it worth it because you get a really good question and you get a good answer, and you get to bring that back to the clinic, into the operating room, and to help living people live better lives and live longer.
So the steroid is not yet approved, but
Yeah,
it's still being
that
used.
was years ago. So it actually, they're still working on it. It's an anabolic steroid that's approved, but you can't get it over the counter. Is
Got
what
it.
I was. It's a controlled substance, just like any narcotic is, but it's not readily available. We were trying to show that there is a good side of anabolic steroids, besides, you know, weightlifters taking steroids to
Yeah.
get pumped up. We weren't using it for that at all. We were using it to treat injured limbs and injured muscles, so that we prevented the shrinkage of the muscle while it's sitting there trying to heal. You can still, you can keep it kind of revved up and functional with anabolic steroids, and actually prevented scar.
Yeah.
Scar is the bane of your existence. You get a gap and you get scar. It's not really a good muscle. It's just kind of scar. So if we could prevent scarification and prevent shrinkage of the muscle during the healing, that's a win-win. And, you know, there's obviously the side effects of
Yeah.
anabolic steroids. So the next study would have been a dose titration. What's the lowest dose we could get the good effect and avoid the bad side effects? But that's downstream.
Right.
Every good study answers one question, but offers 4 to 5 more good questions to study downstream. That's a good program.
Right. It makes sense. I love the idea because physical therapy, I'm a physical therapist, and all I deal with is atrophy
Yeah,
post surgery. Most of my patients come with the calves being so atrophied, or their quads after a knee ankle surgery,
right.
and all I'm doing is just toning them. All I'm doing is strength training, weight training from day one. I
Yeah,
hate to see that one leg is a chicken leg and the other leg is so bulky.
so true. Do you use a lot of e-stim?
Yeah.
I mean, we just had our 51st annual sports symposium we hosted at my university on that emblem back there. We had 500 plus, like 520 registrants, therapists, trainers, some docs, but mostly therapists and trainers from
Right.
all over, mostly in Texas and San Antonio. But and we talked about things like that, like how do we, you know, work together, you know, musculoskeletal oriented, to maximize the bang for the buck, meaning you only have so many precious visits with a therapist or a
Yes.
trainer. How do you get the most yield out of that? What's the frequency? What's the duration? How can you progress rapidly but not do harm to the repair or whatever surgery or injury that they're trying to overcome? So how far can we push it, and what modalities can we add into the mix to
Mm-hmm.
make it, a better outcome?
Yes. I use a lot of e-stim, but with atrophy, like you suggested, uh, stim. I found out, this is my personal experience and observation, that with e-stim, if you combine some static or some exercise, like for knees, I'll load the quads and I'll give them static quads or
Nice.
quad sets.
That's
So they're just using their quadriceps and they're on e-stim. So every time they feel the current, like a strong wave of current, they're contracting. So I have seen that it increases or like
the
multiplies
booster.
the
Yeah,
effect. Yeah,
boost their effort. Yeah, it's like having a coach in their muscle. Like, come on, you can
correct.
do more. That's very
Like,
interesting. Yeah, muscle loves load. So if we
mm-hmm.
can figure out a way to provide the right level of load right up to the brink
Right.
of causing harm, but making it so it's work for the muscle, it does do better. It does,
Mm-hmm.
muscle response to load, like you said. There's a company I was working with. I don't want to name them, but they have their whole engineering thing is it's a lot of physics, but they make it so that even an elderly patient, right after a cuff repair, where we repair the
Yes.
rotator cuff, they can get on the machine and do work in the machine, kind of a system, but it's unlike weights and
It's
typical
passive.
machine. And they can put a harness on an athlete and they
Right.
can run away from the machine on a long cord, and they can dial in the resistance just so they can still get. It's like carrying a backpack, but not the bad ergonomics of a 70-pound rucksack, but you're harnessed and you're tethered, and it gives just enough resistance, and you don't have that, like when you get on a bike, that
Yeah.
first pedal, it's like hard. You have to step on it to get it going. This gyroscopic system or whatever it is makes it so that it's effortless to start, and then you can dial in whatever resistance you want. So there's a lot of new
Yeah.
technology out in the world that helps us with, like, older patients or patients that are just post-op, and we say you can't do active motion, it's just passive. Well, there's no load on a passive
Yeah.
muscle, so we know our repairs are engineered enough to withstand some
Correct.
load. We titrate that load, it'd be a win-win for everybody, mostly for you all in the therapy world.
Yes. I because post surgery they're always immobilized. I get it, but I feel like loading is very important because
Yeah,
the surgery is done and it's done to an extent where the ligament, especially ACL, since we were talking about ACL,
right.
is strong enough after the
Oh, yeah.
surgery. So it's very important to load it and not just immobilize it. So I go for quick quad sets. I go for lots of getting the knee extensions. I go for all aggressive therapy for it rather than just being super conservative and trying to cause more
Right.
atrophy to the muscle.
I think those are great things, and each injury is different. But like you said, an ACL. I did a couple today. We get them walking right away. There has to be a really good reason not to put a shoe on your foot and be weight bearing. And it's not because of an ACL anymore. We let them walk full weight
Yes.
bearing. I'll control them because a lot of them are student athletes and they're wearing backpacks to school and they're worrying about their, irregular surfaces and slippery surfaces in the winter. So we'll lock them in a brace to walk, but they come out of the brace. If they're an athlete, they're in the training room at least twice a day. They're working them hard in the controlled setting of a training room. Us mere mortals don't have trainers twice a day. But when we go see you as a therapist twice a week or 3 times a week, they're out of the brace. They're moving it in a safe environment, in a controlled planar motion. No cutting and pivoting, obviously, because that's too much torsion. But we find, like you said, we get the best benefit with regaining motion and maintaining full extension,
Yes.
and also a decrease detriment of atrophy. They don't shrink away anymore because we fix them quick and we get them right back doing stuff as soon as we fix them.
Yes.
So that paradigm over my 30 years of doing this it's been a game changer. I mean, we don't have the patients come in looking like their little sister's knee, or their tackle, and you're like, what happened to your thigh? Like I don't know, it just ran away. I have no idea. So it's nice to be able to, not lose as much. I mean, they still lose some because you have the injury response, but to jump into therapy after an efficiently quick repair or reconstruction is key to success, I'd say.
Yes. Another thing that I've observed, because we were discussing about the surgery, especially knee surgery, knee hip replacement, I've seen a lot of quick recovery if the
Yeah,
prehab before the surgery is done good, intense, quite a lot of strength training. If we do a good prehab, then post surgery, the recovery is so quick, so smooth, and it just gives the patient a very different feel than the patients who have not done prehab.
I agree completely. The patients love it. Sometimes they say, oh, I only have so many visits on my insurance plan. We're always battling that, like what's your total? And we want to, use them when they matter the most. But doing a couple preoperatively really gives them good muscle memory. They have confidence in their ability to physically get the task done, whatever it is for a hip or a knee. And there's a that muscle memory, I think, to make it as simple as possible. There's a lot to be said for that, because when they go back for that first visit, they know they've done it before.
Mm-hmm.
The therapist knows they can
Yes.
do it, but now they have less pain because they don't have an arthritic joint. They have a new shiny joint. It's smooth and it articulates. And once you get them past the fear of moving something that just had a big operation because it hurts, I get that. It's what pain medication's for a little bit, and anti-inflammatories. But then early motion, once you get their confidence, you all as therapists, once they bend that knee the first time from 0 to 90 over the side of the bed, it's game on. Just getting them to do it. I see all my patients like day one, right after surgery, like the ones I did yesterday, I'm seeing tomorrow morning.
Mm-hmm.
They're going to all bend their knees if they're knee surgery right over the side of the bed.
Yeah.
And then I'm like, good, my work here is done. Off to therapy. You have a high chance for, rehab success, I would say.
Yeah.
So I think it's important.
Also, because you mentioned the medicines, I've seen that exercising, even if it's post surgery, I mean, definitely there's some amount of soreness, and there is, the muscle is tired because of the toning and the gymming.
Yeah,
But I have seen that the patients feel less pain after doing the exercise.
I agree. Yeah, I mean, at first there's a little startup friction. It's more of a confidence and
Mm-hmm.
anxiety. But once you get past that wall, that supratentorial wall of like, no way, no way, you win them over, and they're like, oh, what
Yeah.
else can I do? What other trick can I learn?
Yeah.
then you gotta like put the fear
Yeah.
of God and say, okay, you can't, just because it doesn't hurt now and you feel better, it doesn't mean you can go do box jumping.
Yep.
You're not ready. But keeping it, simple and mundane, and something that the patients can do to help themselves on the days that therapists, they can't see you as therapists or can't see their team trainer. Because, I always tell them, I say, you're getting graded when you go to therapy. So study and do your
I'm
homework.
going to use that, because I keep saying that all patients are like children. You have to treat them like children. You
Yep.
have to give them homework. You have to tell them, okay, now is the time to push, and you have to tell them, okay, don't get super excited. Now is the time to take a break, work on your stretching and soreness, and not just keep on doing the weights.
Right. No, I agree completely. And and it's amazing. It's people say, oh, I don't want to do the little wimpy weights. And like that's what gets you back in the game. I mean, it's a buildup, and you're in that toe region, and then once you're allowed to take off, certainly by 6 weeks, you can almost do anything. You got to start little and got to start slow but sure and steady and keep moving in the right direction, but start quickly.
Yeah.
We still wait. Gosh, when I was a cadet at West Point, I remember before I was in medicine, obviously I was undergrad, I'd see friends and football players that got hurt. The orthopedic surgeons would put them in a cylinder cast
Oh,
for like 6 weeks.
oh,
You couldn't do anything. You're like, that's total immobilization. We didn't get many clots because they were young and healthy, but I always wondered what my teammates are doing. Why are they in this straight stovepipe cast? That's all we had back then. There wasn't functional bracing. There wasn't good rehab. There wasn't, I mean, it was the Stone Ages. It was back in the 80s. I mean, I was there from 81 to 85. But now I see my classmates at the 40-year reunion, and, they all have total knees now, and, they're
Yeah.
55 to 60, and it's a whole different world. But we all remember those days where, immobilization was the rule. But now,
Yes.
I mean, therapists and physiologists have all taught us that motion is critical for success. It helps prevent adhesions and fibrosis in a stiff joint, but it also just gets the whole system running again, getting that engine running, getting the blood flowing. It actually minimizes how much narcotics you need and minimizes the inflammation. It's I mean, there's a fine line. You can overdo it, but I think we're both on the same sheet of music where, some is important and up to,
Yeah. Definitely.
yeah.
I've seen my patients get off their pain meds very faster
Yeah.
than they would if they, because I have a few patients, I'm not gonna lie, that go like, oh, I'm too much in pain and I don't want to
Yeah.
move. And I have seen that they are still on the medications and they're still we're still struggling to get the last ranges of motion, which we
Yeah.
should have got like weeks before.
Yeah.
But it's just that they're too sensitive to pain also, that we take it very slow and very careful.
Right.
So
So
yeah.
you mentioned it, it's all about pain. And, as surgeons, we look to our anesthesia colleagues, to therapy, and to our trainers to kind of not only do the prehab, but that multimodal pain management is the buzzword now in and around surgery. So if you're getting a big knee surgery, a reconstruction, or a knee replacement, we do a lot of things besides just piling on narcotics, giving you a whole canister of oxycodone. We do that because you can't have people writhing in pain at 2 a.m. on the first couple after surgery. But I can't remember the last time I refilled a narcotic prescription. And I do big surgery, it goes on. We do lots of things. It's like alphabet soup when you dictate the op note. But patients are only on narcotics for like 2 or 3 days sometimes, not and because they're taking Tylenol, they got a sensory block during surgery so that they weren't writhing in pain. I always tell them, I said, we want you in the lazy river by day one after surgery, but then you get to dial it back.
Mm-hmm.
You don't have to take it. It's not like antibiotics. You have to take it for 10 days. We say it's there for you. And I use the term, it's icing on the cake. If the Tylenol and the anti-inflammatories don't do the trick, the narcotics are there to kind of, dial the rheostat back from a level 10 pain down to a 6 or 7. And then you can titrate it. But the sooner you can get off, they all agree, even if they took a lot of narcotics and they're a back pain patient, they feel better off narcotics, right? I mean, when you see them in therapy, they just look better, they feel better.
Definitely. 100%. I agree with you there. So you like a lot of research.
We do. We do a lot of research. We're one of an academic institution, so we have med students and PhD researchers and nurses and you know nurse practitioners and allied professionals that do a lot of clinical research with us. I don't do as much benchtop and no large animal research. I'm too busy. We capture a lot of data clinically now to kind of refine everything we do in the sports medicine world, certainly.
Yeah. Well, why not rats? I would think
You can do rat. We do mice even. We've done rabbits, rats. Some places it's really reasonable to do rat surgery. A lot of like pharmacologic or
yes.
dose titration things are done in rats. I know. Orthopedics is just really hard because
I see.
to translate the instrumentation and the size, like if we're doing cartilage research, we need certain surface area to do some even tiny analogous cartilage plug in a tiny rat's knee and compare that to a
Yes.
large plug in a in a human's knee. There has to be a little bit of concurrence there where if it's too small, it's like you can't, if you have to do it under a microscope, I say it's probably not as translatable to humans. We don't use a microscope in orthopedics. Well,
Yeah.
unless we're hand surgeons and we're putting the vessel back together. But in general, so a little bit of a larger animal that's going to see similar loads because we're oftentimes assessing the engineered resiliency of the repair. how much load can it take, how much flexion and torsion for like a cartilage plug. When we look at like, can we weight bear fresh restored cartilage lesions if we do a transplant? And the answer is yes. If it's rim loaded, so if I have a surface that's this big and I replace the center 50%, as long as there's enough cartilage shouldering on the sides of that round lesion, you're running across the condyle that's intact. So you're not really bearing weight through the central lesion that I might have put a plug in to resurface it. And patients teach us that break our rules. Like we go, aha, you fail. We learned something. Well,
Yeah.
class cool. You didn't follow my instructions, but in so doing, you moved the ball down the field. We learned that you don't have to be non-weight bearing after a lot of surgeries. You can bear partial weight for a couple of weeks, and then it's a fracture healing model. A lot of these osteochondral allograft plugs. So
Yes.
as soon as the fracture healing model is the 6-week model, once you get 4.5 to 6 weeks, you can bear weight. So, and then we get them out of their brace and start making them walk like normal people. So there's less kinematic demise. They don't have to relearn how to walk with a bent knee gait. Because some, used to be we'd keep them in a brace for 12 weeks, it seemed, for a lot of things. And it was hard to teach them to walk again. They'd walk around, walk like this, and they're still walking like a peg leg. You're like, when are you going to walk with a bent knee? But you get so dependent on the brace
Yes.
and the crutches that I think you guys see the struggle more than us. We see them when they come back at 3 months. We're like, why aren't you walking? That's crazy. But they, you just learn how to walk with a straight leg gait, and then you forget to bend your darn knee after a while. So anything we can do together is taking care of these injured folks as therapists and trainers and surgeons is very symbiotic. I mean, and we have to be talking to the patients with the same language. Otherwise, they get confounding
Yes.
instruction. We're like, move, and you're like, no, or vice versa. Like we have to be singing from the same sheet of music.
Which is why I love to stay in touch with the doctors and the surgeons, especially neuro and ortho, given post accidents, number one, and geriatrics, because they're the most anxious ones.
Yes.
And like I mentioned, it's not even about staying immobile. It's more in their head. So they think that if I do it, if I put weight, it might snap, I might have a fall, I'm not too confident. Every day I'm working with the patients post surgery, and every day it's just me giving them confidence most of the times. So I keep telling them, hey, come on, let's try it. I know you're scared of putting weight. Try 25%, try 50%, but just try it. And then they love it that they keep going. They're like, I'm at 50 counts, I'm at 70 counts. I'm like, no, okay, stop.
No, I agree. It's the small gains that if they gain their appreciation of their own gains, and we don't make a big deal of it, but we just tell them how useful that is, that it's a self-fulfilling prophecy. They're on board and they're like smiling instead of depressed. Their whole mantra about progressing and getting better is, you've won the patient over. It's great.
Yeah. How much do you think, like, the psychology, how you must be seeing a lot of patients who come from fear and post
Yeah.
after accidents, especially like motor accidents and
Yeah, actually, our athletes, we have sports psychologists on every faculty, on every every group at every major school that I've ever worked with, including UTSA, where I'm the head orthopedic surgeon now. We have a sports psychologist that we lean on heavily to kind of get the athlete who's basically missed a year of football. They had their ACL reconstructed, had a meniscus repair. They basically haven't hit another player with a helmet on for a year. It's hard to get Johnny back out on the field and cut and pivot when he knows the last time he cut and pivot, he was on a stretcher and carried off the field to the locker room. So that getting past that supratentorial psychological barrier of like, what if it happens again? And helping them realize that if we do our part and you guys do your part as therapists, that and the patients are on board, it's a win-win-win, because we try to appropriately over-engineer God-given anatomy and function. You guys regain function as fast and safe as possible, and the athletes then kind of get the switch flips with a little group therapy and just seeing their friends that are maybe a phase ahead of them going, look, there is a pathway forward. This is not a dead end. You don't have to be on crutches and a brace forever. There is a progression, and here's the plan. And you just keep telling them where they are along that pathway. And once you get them to believe that, you know, that they're pushing you to progress them instead of being resilient and like, I don't think I'm not ready yet. You're ready. It's time. And honestly, in a training room setting, especially old school where we have like 6 beds, when everyone's at a different stage of like rehabilitation, it's kind of nice to feed off of each other in a good way. You know, it's very, you know, if you feel like you're not the only sad athlete or injured person in that dire straits, that there's 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 strength in numbers, I guess, psychological strength in numbers. When you think like, hey, it's kind of like we're all pulling through this together. We're kind of in the same boat. We're just, you know, different stations in the boat. Like I'm the front row guy. I'm getting ready to go out in the field. I just got here out of the OR. Tell me what to do next. Am I going to make it? They actually feed off each other, I think.
I love that because like at my place also we've started like community. I always wanted to build a community with my patients where they're comfortable. I have seen a patient crying one day because she was so lonely and she didn't want to do physical therapy anymore because she was in so much pain. But then that very day she met another patient,
Right.
same age, single like her, and they both just connected. And today she came in, the patient, she was smiling and she had so much stories just to gossip with her
Yeah, it's
friend. She
awesome.
kept out on exercises just to sit and chat with her for an hour.
Right. I mean, there's so many online therapy algorithms now that do build on that community. I mean, there are patients across the world and across the country sharing very similar experiences. That shared grief, if you will, makes you get out of the slump of
Yes.
so depressed. I'm not going to run for 3 months. Like, yeah, you and a million other people jump on board. We got a pathway forward. So there is literally strength in numbers, I think, and digital era that we're all in really helps promote that. They don't have to be in a small town all by themselves as the only ACL patient that week. They can, you know, there's that strength in numbers if you just dial into the right, you know, app, if you will, or whatever, you know, is the newest gig. But the progress is being made in every realm, and I think taking advantage of that. I mean, COVID was the good side of COVID. The glass half full is telemedicine's great.
Yes.
We it matured very rapidly because it had to, but you know, I can check in on patients like we're doing right now. I can say, hey, you look great, bend your knee. And I, you know, they don't have to travel 6 hours across Texas and still be in Texas to come see me. I can see them remotely and kind of reinforce what they're doing with their home therapist so they don't have to travel all the way to me because it's translatable. You know, I don't have to put my hands on their knee. I just need to say, oh, look, your knee's here. Now it's here. Now it's here. Oh my gosh, you got all your flexion back. I mean, it's very empowering because I can see them a little more often and it's less, you know, cost and expense and time for everybody involved. They could do it. They could have just a chat with us on the way home from work. You know, no time lost. It's just dead time anyway. But they get a little chat and a little reassurance out of it. Like, hey, how's therapy going? Hey, I'm looking forward to seeing you at the 3-month visit, but not maybe at the 6 because you're on autopilot. I've got you covered. I know what you're doing. I get the digital reports. We're chatting now. It's very empowering, I think, to patients that they're in a they have an ability to contact their healthcare providers, whether it's their therapist, their trainer, their surgeon, or the whole team that I work with, at any time. But it's not a burden. It's not like, oh, they're not just walking into the middle of your clinic. There, you know, there's certain times you can set aside, or it can be passive. They can just enter it in the digital record, and when you get to it, in between cases, I answer questions all the time. I go, oh, look, Mrs. Smith is worried about her rotator cuff. I'm like, you're fine. I just read the therapy notes. Keep doing it. And it's very nice. I mean, that's a tangent we just got off on, but I think there was more talking about the empowerment of just the digital platform. I think is just, I mean, it's just going crazy now in a good way. I think the potential is endless, actually.
I'm so glad that you are a surgeon and most of your work depends on in-person or manual.
Yeah.
Part of that, you are so supportive of telehealth, telemedicine, because it helps you, like you said, it helps you check up on them when you don't have to waste time, nor yours nor the patients. You can just check up on their ranges, you can ask them for any new complaints, any new symptoms, and that's it. The patients are good to go, they can get back to their jobs, their work, their therapy, and you get a satisfaction that, okay, so everything's going right with this patient,
Right.
or patient XYZ needs to come back for another visit because I think there's something sketchy going on.
Right.
So I love
You get to spend quality time with the few people that really need. We always tell residents, when our learners, like, you'll spend 90% of your time taking care of 10% of your
Yes.
patients. If you have the right system with the right team members, therapists and trainers and everybody involved, you'll spend 10% of your time taking care of 90% of the patients. That's a good sign. But then you're available to take care of the, we'll call them the problem children, the ones you have to keep a closer eye on and maybe need a little more pats on the back, or, you know, a little more push, a little more whatever, attention. But it's doable that way in that model. You don't have to see everyone back the same exact overall flow. You want to see them back at waypoints, but people get to those waypoints
Right.
maybe differently. So it's nice to have a little bit of variability and capable variability built into the system.
Being a sports surgeon, you come across a lot of recurrent injuries. How do you think is I don't know if you've done any research about it, but how do you try to minimize those recurrence of
I
injuries?
mean, a lot of times I love looking like at injury film, and we look at like our throwers and look at their form. We look at our, you know, our running and jumping athletes, maybe our volleyball players or soccer players, and we see how, you know, at West Point, when I was there, we did the original jump landing study. It was a NIH sponsored multi-institutional study between, I think it was Chapel Hill, but it ran between the Naval Academy, Air Force Academy, and West Point. And we had every cadet. That's like maybe 12,000 cadets, because there's 4,400 Army cadets. There's that many midshipmen and that many Zoomies at the Air Force Academy. We got all this data on, you know, a good 1/3 of each of the corps of cadets, the three institutions, and it was a lot of hands-on. You know, we created these platforms. We didn't, but we had the Chapel Hill folks did, and we did all this jump lining data with high-speed video analysis, and we could see that, you know, if you land with your knees in valgus, you're doomed. You're going to get an ACL tear, and we could help figure out ways to mitigate that, and we could train people out of that poor kinematics, of poor jump landing technique. The problem is there's a fade. I mean, the teaching is great, but if you don't keep at it, there's a loss of learning, and you kind of go back to your, you know, pre-educational ways. So it demands, unfortunately, at this point at least, recurrent training and,
Right.
you know, like updates, if you will. And it's even more true with the younger female athlete. That's probably, you take an adolescent, a 13-year-old girl is way more at risk for an ACL than a 13-year-old boy who's more like an 11-year-old boy, because it's not even mature. But
Yeah.
you know, it's growth spurts, it's hormones, it's female, it's the whole body. More women tend to be more knock-kneed, and we tend to be
Yeah.
aggregate more bow-legged. So that's
Like,
effective. But so all those things, those unmodifiable, non-modifiable risk factors, you can't change them. You can just work with them, right? So we can teach them ways to work through it when they're learning the skills of jumping and landing, and that's like
yeah.
every sport, right? Basketball, probably not croquet, but, you know, everything else. It's very empowering to see, you know, when you see aggregate year-end data, you're like, hey, we actually knocked down the amount of ACLs this year because we did this ACL team training module or whatever it is. And there's different modules available out there. It does demand vigilance and diligence to kind of keep at it. That's the problem. But if you save a couple ACLs a year, that's a win, I think, in any subpopulation. It's gonna,
I had
especially if you have all daughters. If you have 3 daughters, that's 6 knees, man. You're like, one of your daughters gets a knee ACL, and you're like, oh man, that's 5 more knees that are possibly at risk. Oh my God. I have friends that think like that because they're team docs like me, and I'm like, I don't let them do anything. I'm putting them in a bubble. I'm like, you can't do that.
Yeah.
You can't do that.
That can also cause other risks and other injuries
Right.
to be.
Yeah, I mean, you just have to work through it. A little bit of prayer,
Yeah.
but a lot of work.
A lot of training. So just train well. Just focus on the training.
Yep, strength, quads, balanced hamstrings, and core strengthening. Right, you guys talk
Yeah.
about that a lot, right? Abductor strengthening, glute strengthening. It's just like the throwing athlete. I mean, I'm a hip surgeon too, so I do hip arthroscopy, and it sounds crazy to tell a pitcher, it's not your throwing technique, it's your weak hip abductors. You're weak and dizzy. Your hips are terrible.
Yeah.
And they're like, but I'm a fastball pitcher. I'm like, not for long, not with those hips. You're not. I mean, it's at first they're like shell shocked. You're like, yeah, it's all in the hips. It all starts in your core and your hip and your glutes. And it's true. I mean, if you have tight hamstrings as a guy and you're long and lanky, you may have the advantage from height early on, but if you don't take care of it with good therapy pre, pre-event and post-event, you're not going to last long. I mean, your days are numbered. And that you put a little fear in them, and then they're like, "Oh, I'm listening. I'm all ears."
I
Do
think
out
that's
of
the cure
tech.
for most of the
Yep.
problems. Yeah. Because that's the one muscle that none of us work out.
Right.
Like that wouldn't be my go-to muscle for when a patient comes in. So
Not,
I've started to focus a lot on the core because I've seen a lot of back pains just by when a patient comes in with a lot of back pain and I start strengthening the core, I see that the back pain goes away immediately without even focusing on the glutes or the hams, which another thing that I've seen is hams tightness is
oh yeah. Well,
so.
it gives you that whole pelvic tilt, and then it gives you that you lose the normal curvature of your lumbar spine. Then everything's going downhill after that. So I mean, I get young kids in, and I do their ACL, and I look over at mom and dad. I go, "You got to work on his hamstring tightness. He can't even touch the ground with his fingertips.
Yeah.
I mean, I can put my palms on the ground, not flat, but I can cheat a little bit. But if you start out at age 14 and your fingertips just touching the ground, your hammies are tight. And we tell them, I said, you're going to get a hamstring strain, you're going to get a hamstring rupture, you're going to lose a whole season, and that's an unforced error. I say you can mitigate that. You can go to therapy. You can get into some multi-sport kind of training to kind of change it up. If you're just a third baseman your whole young life, I mean, we talk about this with kids all the time now. Not only get out there and play sports, but to mix it up. Don't be a one sport
Yeah.
athlete because you get into trouble. I mean, the body's meant to move in all directions, and it likes surprise.
I have a kid. He's 8-year-old kid. Very new recent case that I got, and I asked him what sport you play, and he goes like, I'm a goalkeeper. I'm like,
That's it.
okay, soccer. He's like, no, I don't play soccer. I'm just the goalkeeper. That's all I do. I'm like, no, so you do play soccer? And he's like, no, I don't run around. So I'm like, okay, there you go. So let's start by that. We started running, and he had, again, because he's a growing kid, he has the lock knees, and because of that, he has recurrent falls while he's playing. So we started working on the adductor because adductors are quite tight too. And then we started working on his running, on his balance, and because he's an athlete and there's no major injury, we just jumped into the plyometrics,
Sure.
and I've seen so much improvement.
Oh, that's awesome. That's good. You saved him. That's good. I mean, and if he talks to his friends and his mom talks to another kid's mom, I mean, it is at the low level that's how information is, passed on. And it's everyone you save is important. I mean, it's not saving a life, but it's saving them from injury
Yeah.
that, they otherwise have to sustain. Yeah, it's sad when they get an injury and you're like, God, that was so preventable. Oh, I mean, sometimes it's not. You blow out your ACL or you break your wrist and you're eating good and healthy. You just that happens. That's why there's people like me, I guess, around. We can get you through it, and people like you that can help do the therapy. But so many things, so many injuries are not preventable, but mitigatable, and you can diminish the overall morbidity of it. I think if we all
Right.
worked a little harder on the prevention side or the preparation side, like what do we say? We call them weekend warriors. I'm one. I'm 60, so I'm busy. I'm teaching courses. I'm on airplanes half the week, or I'm in the operating room. Then I go out and try to catch up, like, like run 5 miles instead of two. I'm like,
Yeah.
just find time to do two more. Um, yeah, I mean, half of the shoulder injuries that I see are overuse
Yes.
injuries, and you're like, God, like you don't have to go. It's not like A or B. It's a spectrum. It's a rheostat. You don't have to either not go to the gym or go to the gym and act like the 18-year-olds. You can act like a 45-year-old if you're 45,
Yeah.
and do, you know, safe exercises within your safety envelope, and that's what we need to teach them. What is your envelope of safety, so you don't burn past it like a knucklehead and walk in with like, ah, oh, tore my rotator cuff. Like, what? How'd you do that? That's
And like you mentioned, knowledge is so important. Like for the overuse that you're talking about, most of the patients that I've seen have the retractors. They don't use their retractors.
right.
They have shoulders. So yeah,
Yeah,
we
yeah. Your own shoulders getting in the way. It's like
yeah
you're statically impinging because your shoulders are rolled in, and anytime you lift your shoulder up, it's like you're banging into the acromion. If you get your shoulders back, you have more clearance, right? So it's true. So half of our shoulder patients we send to you all and say, what's the buzzword the last 20 years? Dr. Kibler out of, I think, Kentucky, Ben Kibler is a big proponent on scapulothoracic dyskinesia. Fancy word for your scapula is all screwed up. And you got to get your scapula
yeah
protracted, and you got to stand tall like you're in the Army at parade rest, and,
yeah
you know, make your shoulder less prone to injury. I mean, it saves people's shoulders. It saves people from surgery
correct
because, you know, you can correct a lot of the underlying kinematics, I think, through adequate strength training, therapy, plyometrics, everything we've been talking
right.
about.
How what inspired you to join in the sports medicine ortho?
Well, I was a injured athlete in high school. My dad was in the Army. I was in the Army through West Point and then went to med school. So my job in the military was to take care of our wounded and injured soldiers and their families and all the people that, you know, were in the Army or military system. So it was more of a closed system mostly. I mean, we took some civilian trauma too, but in the smaller community hospitals like at West Point, we were responsible for the 45,000 people that helped the 4,400 cadets get through 4 years of college. So it was a closed system, and we were responsible for their care. And as an injured athlete, I was back at my alma mater taking care of my kids when they got to West Point. So
Yeah,
it's very fulfilling, but I think, you know, that's everyone's story that goes into ortho. Like, well, after I sustained my bad knee injury, I decided I wanted to help people with bad knees. You know, like it's the same personal statement as everyone. But being injured, I didn't know anything,
yeah.
you know, and I realize now I'm empowered to teach people a little bit more about their injury so that maybe they get through it easier, better, stronger, faster. Um, yeah, I mean that's the main part. Plus, I was an engineer at heart, in the and orthopedics is human engineering. I mean, you know, we're putting things back together, making a better birdhouse out of one that got broken.
In the heart,
That's right.
poetic. Yeah. West Point, isn't it in Dallas?
Now, West Point, the U.S. Military Academy, is about 50 miles north of Manhattan, right up the Hudson River. So it's the George Washington Bridge. West Point is right at the right near Pittsburgh. It's right on the Hudson where it takes a turn. Strategically placed there because during the Revolutionary War there was a major kink in the river, so the British ships, if they ever decided to come down, would have to really slow down and go broadside,
Yeah.
and they could have been cannonballed from the fort of West Point. But
I
they never threatened to do it because of the strategic location of West Point. It was beautifully placed on the cliffs of the or the rocky ledges of the Hudson River. Very strategic point.
I remember attending a baseball match between Air Force and West Point.
Okay, was it
Yeah.
in New York?
No, it was in Dallas actually.
Oh, we you know, even the Army Navy games not always played in Philadelphia. Sometimes they move it to Giant Stadium. You know, they want to move it around because they want people to see it and experience it. So a lot of the service academy big games, big sport events, they'll move to a neutral field just to get a different set of eyeballs. You know, 40,000 to 100,000 people watching it, so that people are more exposed to what is this academy thing. Like, my son and daughter could go to the Air Force Academy. I mean, it gets more people knowledgeable about these pretty amazing academic institutions. Like, you know, what is it all about? So through sports and television, it's nice. But if you can move the events to where the people are, that's
I
even better. Little hand,
also,
little hand.
I agree with you. I always wanted to work for the military as a therapist because I see a lot of amputation that
Uh,
happens in vets, and I wanted to do that. I even interviewed for the Navy, but they need to have a citizen.
ah,
They need, yeah.
yeah.
So I was like, oh, and they qualified me. Everything was good, so that didn't work out. But I'm still hoping maybe in the future.
Yeah.
You never know.
We have the Center for the Intrepid here is a DoD civilian enterprise. I think it's where they do all this cutting edge work on our war wounded amputees. It's amazing. Right here at Brooke Army Medical Center at Fort Sam Houston in San Antonio.
Oh,
Um, it's amazing. One of the folks that ran it, Dr. Alderetti, one of my partners, is now he retired from the military, left him in great hands. He's with me now as a partner, and we just did a gentleman who had a mangled extremity. Great case. I have to share
yeah.
it with you. So he has a mangled lower extremity. He's going through the psychological battle. Would I be better with an amputation or not? He had a lot of infection and trouble in the lower leg and ankle, but his knee's unstable. He had an ACL and PCL deficiency. So my partner and I were like, he's like, Tommy, you got to fix his knee so he can get an elective below knee amputation instead of an above knee amputation. So I was like, I've done this before. And early in the war, we had a couple people sent to us at West Point because we were the sports medicine center that we were with our sports fellowship there. And we'd get war wounded people. I did the same thing. A young soldier had a BK already, which was really hard to work with. There's no foot or ankle to lean against during surgery. And he
Yeah.
wanted to keep his below knee amputation, but he had an ACL deficient stump, right? So I did an ACL on his below knee amputated knee and kept him in the game. He got back on active duty. He was a trainer of trainees. He wasn't kicking indoors, but he was teaching people
Yeah.
how to do it back in schools. And, you know, he got to keep his military career going and get medically boarded out, as far as I know. But we stabilized his knee. And as you know, it takes so much less work to be a community ambulator with a below knee versus above knee. You stop walking in your 40s. It's just too hard on your heart and too much work. So that's what I just did to this guy. I did ACL and PCL on his knee. Now it's stable. He's moving it already, walking around on it. And now he's not excited, but he's all on board. He's like, take my leg off. I want to use my knee. Give me a BK and a prosthesis. That he fixed my knee. There, I rhymed.
I love that.
That's my most fulfilling case this week. That's kind of like, that was a big one.
This week?
I did it a week ago. Yeah, a week ago Thursday. I just did it. So he's already out moving his knees 0 to 110. I mean, he's like,
Wow.
go, go, go. You know,
This is your weekly thing?
every week I do about 12 to 15 cases.
I love it. I love it. And I'm a little bit jealous because I cannot.
You have to find a surgeon who will allow you to come and watch a couple, because after you see one, then when you work on them, you just have a little bit more 360 understanding about why or why not they may be hitting a wall in therapy. I mean, I tell our trainers, like, if you haven't seen one of everything we do to your athletes, shame on you, because it's an open door at my OR. I've got people not coming in and out like Grand
Right.
Central, but like there's a lot of people watching just so they can all learn, like, oh, that's what that x-ray means real time. Like, oh, then, you know, then they understand too why some people hit a roadblock and how to get them past it, because they have a little bit of knowledge and they saw it happen, or they saw the graft get put in and they go, oh, I can see how that might cause some scar in the front of the knee. It makes more sense to them. They put it all together.
Yeah. I did actually assist in a few steroid injections. It's
Oh,
not a big thing, but like it was something new that, and it's not practiced in India. So when I was practicing in India, I never came across that. But during my internship, I was working with a orthopedic and a sports surgeon as well.
got it.
He was just like you know, always excited to teach. He was my go-to person for every case because his office was just uh uh you know, just down the hallway. So
Right. In and out of both. He's in the OR, in the clinic, yeah. That's nice. It's a great
the
setup. Very efficient.
come from his office and do the PT and go back to show him, and I used to walk with the patients to just speak about the case, and it was such a good bond between the PT surgeon. That's how it should be.
Oh yeah.
And
I mean, we have combined conferences all the time. Like we just had this 2-day annual kind of sports medicine symposium update where we got everyone that wanted to come by. I've been doing it, but it's been going on for 51 years here in San Antonio straight. It's like one of the longest running meetings in our area. So it's impressive to get that many people to come in. I mean, it's good CME credit, I guess, CEU credit, but that helps. But make it very fresh every year. All the talks are new and updated, so it's kind of like cutting edge sports medicine and orthopedics. It's good.
I love it. Yeah, that's how it should be, because I had a very difficult ankle case, and I remember we were trying everything, but we because ankle is small bones, small ligaments. It can be very complex
Oh yeah,
sometimes, and you can't focus on one muscle, one ligament.
it either all works together or it fails apart. So it's really that symbiosis of the synergy of getting the motion, getting the ligament structures, and the muscles that power the tendons that go around the ankle. Oh my gosh, that's got to be really hard to work on. And then we put walls up and say you can't weight bear
Yeah.
on it. Partial, it's hard to get them through that. So do you use a lot of aquatic therapy for lower extremity stuff?
Yeah, we didn't have aquatic therapy. I'm certified in aquatic therapy in India. So I was always telling them, come on, guys, you should just have just a
Right.
pool. I need a pool. That's all I need.
We use there's all these treadmills now that like zero gravity kind of things. I won't name the proprietary names, but there's a couple on the market. And then we have underwater treadmills in our training room for our D1 athletes and the team athletes out at UTSA,
Yeah.
and get them in there as soon as we can. Really, it speeds up the whole paradigm of therapy because they get to that next phase of therapy because we can make that 260-pound lineman 120 pounds. Never been that light on his feet since he was 12. So we can do things sooner, a little safer, even in our big athletes that would maybe overload a joint too early if we let them get out on the real field on the turf. So that's a blessing to have that capability. I mean, I just go and watch it. They do it. I'm like, oh, that's pretty impressive.
Yeah, both water and land therapy combined together
Yeah.
is showing miracles, and I love it. I was just speaking with an aquatic therapist all the way from Germany, and he was telling me it's on one. He's one of the first few people that I interviewed actually,
Oh,
and he was telling me all about the magic of aquatic therapy and how just going in water and just even walking underwater
yep.
can can help, you know, with so many things, with so much knee pain and hip problems. That's amazing. And I it's amazing how we're using this technology and moving forward with it.
Yeah. No, I love it. Anytime anyone can get in a pool. I mean, we're in South Texas. You can be in a pool outdoors like 9 months out of the year at least. And one of the months it's probably too hot, and only one is too cold, and that's probably January, February. But it's people are. I mean, we use a lot of aquatic therapy when possible. It's nice because, especially in our bigger, heavier patients, when they have
Hmm.
rotator cuff injuries and arthritic knees, they need crutches or a walker to walk, and you're like, well, you just got your cuff repaired. You can't really, but you can get in the pool and be buoyant and still move your arms and do safe, minimal resistant kind of dialed in therapy. The water's the magical resistor, so it's great. It's just like this company I will mention, OHM. If you look them up, I don't even know what it stands for anymore, but OHM. You see them online all the time now. They have athletes running, and it really allows us to do what we want to do sooner because we're unloading the joint and not creating such super high startup forces. That startup friction is literally negated, so we can get our cuff repair patients moving, and they're doing it. So it's kind of active assist. It's not purely active, but they're getting that hugely beneficial motion, and it empowers therapists to be in, like, it's multiplicative because you could put 5 patients on these machines, and you could be just the symphony of the orchestra person going, okay, and you're taking care of through the machine 5 people instead of one at a time. It's kind of very empowering. I mean, they're expensive, I'm sure, but the prices come down with volume. But there's a lot of companies out there that are trying to, push this paradigm forward to give you guys the power of almost one-on-one type therapy, but really multiplicative. Like you could do 5 or 6 at a time, all in front of you. It's like running like an aerobics class, except it's not aerobics.
It's so different talking to you because I've been in Texas, and it's such a one-on-one feeling. There's not a lot of crowd, and then I come to New York, and my practice is in New York, so it's you have to keep going. There are people already waiting.
Oh yeah.
So you have to hustle, or you're losing business. You're not doing anything, and it just falls like a domino. So yeah, which is why I love and miss Texas.
Texas is great. I love it. I've been here twice. I was here in the 90s till '01, then moved up to West Point, retired from the Army in '09, and then finally made our way back down here in 2016. So it was nice.
That's
Was
nice.
it in Connecticut for a while? I just saw on the screen UConn tumbles. They were number one lost today. I used to cover the basketball team there. I'm like, oh, they lost. They've been the number one for a couple weeks, the men, and they just lost tonight. So I don't even know who they lost to. I just saw it up. UConn tumbles. I'm like, oh, they're still my team. I like them. Like, yeah, it's basketball, but we have great basketball down here too. But football rules in Texas, I'd say. If you had to put a different, what type of like sporting apparatus would you put over each state as an emblem? A big football go over Texas.
You would say football or baseball?
Baseball too. Baseball's huge
Yeah.
because you can play it more of the year outdoors. But God, Friday Night Lights, it's high school football. I mean, the high school stadiums here look like pro establishments.
Yes.
And small town or county, and you're like, that's a nicer locker room than I've ever been in my life, and it's for high school kids. It's like, it's incredible.
Yeah.
They take it seriously. Yeah.
What plans and upcoming goals for the coming year?
Just to stay at the cutting edge. I'm 60. I just turned 60, so I'm still teaching all the time, at least once or twice. I'm going to China for an 8-day tour, teaching orthopedics and sports medicine, mostly knee stuff, from Beijing to Shanghai and all in between, with one of the companies I teach for and consult with. So I just want to keep, there's always things to learn. And even as I get at the 30-year mark of practice, I'm like, my mantra is always learning, always absorbing, always sharing. So it's fun. Keeps it exciting.
I love that. What are the last few words that you would like to tell our audience out there?
So we need to do more things like this, kind of multi specialty, because I think it's so empowering how we teach and learn from each other, and that it's that cross pollination that creates synergy and progress. So that's my final words.
I loved it. We've been trying so hard to just get on one time, and it's been.
Oh, I forgot the hour change, or I just got off a plane and it was late. I'm like, oh, I missed that call.
Yeah.
I travel too much, so.
I love it. I love it. Please keep doing it.
Yep.
And
I will.
I love the conversation. It was so, it was very different today.
Good.
With you.
I don't know what it's been like because I haven't had a chance to watch you. I mean, I forget how we linked up on probably on Instagram. You contacted me, I'm sure. And then I obviously didn't know how to follow you. I do know how to do that, sort of, but probably by sometimes. And
but I love it. Yeah. You're doing
all right.
an awesome job.
Thank you.
always so inspiring. I keep looking at your videos, at your work, and I am so glad that I connected and we're here. We're able to talk so much, and I'll keep discussing more of my cases with you because I think that you could be like my go-to person for ortho, and I love ortho. I always wanted to do ortho MSK, which is why I did my PT in it, and I love that you're out there not just practicing it but also teaching it.
I love.
That
Yeah, I learn when I teach, so that's good.
I love that.
Yeah. All right, I got to take my dog for a walk. He's knocking at the door over here. He's like, have a good night.
Have a lovely night. Bye bye. Take care.
Bye.
Thank you for listening to our talk about health. You can follow me on Instagram at bhavna.devnani, on Facebook at bhavna devnani, and we'll leave all the information in the description below. Thank you.